I am Dr. Kilpatrick. Today, we will explore the frontier of lipidology, the transition from palliative dietary management to molecular-level intervention in familial chylomicronemia syndrome, or FCS. We will analyze how silencing the ApoC-III gene drastically lowers triglycerides and reduces the incidence of life-threatening pancreatitis. Key highlights include the pathophysiology of ApoC-III, why this protein is the ideal brake to release in triglyceride metabolism, ASO versus siRNA, a comparative look at the molecular mechanics of olezarsen and plozasiran, clinical efficacy, assessing the latest data on triglyceride reduction and long-term safety profiles.
Patients with familial chylomicronemia syndrome, or FCS, present with an extreme physiological burden. Their fasting triglycerides routinely exceed 880 milligrams per deciliter, turning their blood highly viscous and lipid-dense. Traditional lipid-lowering therapies, including fibrates and statins, fail to correct this. These drugs rely on stimulating existing metabolic pathways to clear lipids, pathways that are genetically broken in the FCS population. To bypass these broken pathways, clinical lipidology has shifted away from broad-spectrum metabolic modulators and towards sequence-specific genetic silencing. The target for this approach is apolipoprotein C3, or ApoC-III. This specific glycoprotein acts as a central regulator of triglyceride metabolism in the bloodstream. This animated diagram demonstrates the clinical impact of targeting that protein. We see a steep 80% plunge in ApoC-III levels, overlaid against a synchronized proportional drop in fasting triglycerides. Two distinct pharmaceutical agents have been developed to achieve this exact outcome: olezarsen and plozasiran. Olezarsen is engineered as an antisense oligonucleotide, or ASO. Plozasiran is constructed as a small interfering RNA, or siRNA. Both molecules are designed to lower triglycerides by silencing the ApoC-III glycoprotein, but their physical structures and intracellular behaviors are distinct. These contrasting molecular pathways dictate the clinical application of each drug, directly determining why one requires monthly dosing and the other can be administered quarterly. In healthy triglyceride clearance, an enzyme called lipoprotein lipase, or LPL, sits on the endothelial walls of blood vessels. LPL hydrolyzes the triglyceride core of chylomicrons and VLVL particles, breaking them down for cellular energy or storage. The core genetic defect in FCS is a deficiency or dysfunction of this exact LPL enzyme. Without active LPL, massive amounts of lipid particles accumulate in the plasma. This animated diagram shows a hepatocyte membrane to illustrate ApoC-III's normal function. It acts as an endogenous inhibitor. When a lipid particle approaches the LPL enzyme, ApoC-III protein structures physically block the interaction, delaying clearance. ApoC-III also has a secondary function. It blocks the hepatic uptake of triglyceride-rich lipoprotein remnants by acting as a physical shield over the LDLR and LRP1 pathways on the liver. In a patient with FCS, the LPL enzyme is already inactive. This makes the ApoC-III-driven blockade at the liver receptors the dominant reason for extreme hypertriglyceridemia, fully trapping the lipid particles in circulation. Removing ApoC-III from the system dissolves this shield. The triglyceride-rich remnants immediately flow into the LDLR and LRP1 hepatic receptors for clearance. This hepatic clearance mechanism operates entirely independent of LPL activity. By creating this molecular bypass, the liver can rapidly pull massive accumulations of chylomicrons out of the bloodstream, even with a genetic LPL deficiency. Because ApoC-III functions as the dominant metabolic brake in the absence of LPL, genetically silencing its production provides the specific mechanism required to restore lipid clearance in patients who are refractory to standard therapies. Both olezarsen and plozasiran utilize the same delivery mechanism, a GalNAc conjugate tag. GalNAc ensures extreme liver specificity. It exclusively targets and binds to the azioglycoprotein receptor on the surface of hepatocytes, preventing the drug from interacting with other organs. The divergence begins inside the cell. Olezarsen is a single-stranded antisense gapmer molecule. This split-screen animation traces the two pathways. On the left, upon entering the hepatocyte, olezarsen bypasses the cytoplasm entirely and is transported directly into the cell's nucleus. Inside the nucleus, the single-stranded ASO identifies and binds perfectly to a complementary sequence of ApoC-III pre-mRNA and newly formed mRNA, forming an RNA-DNA hybrid before the message can be fully processed.
This specific hybrid structure recruits an enzyme called RNase H1. The enzyme binds to the site and enzymatically degrades the RNA strand of the pairing. With the RNA strand destroyed, a stable message never reaches the ribosome, and ApoC-III protein production is halted. The biological limitation here is duration. The antisense machinery, along with the ASO itself, clears from the hepatocyte nucleus at a rapid rate. Because the drug is cleared quickly, the suppression of the target gene is relatively short-lived. This rapid nuclear clearance requires olezarsen to be replenished frequently. It dictates a strict once-monthly subcutaneous dosing regimen to maintain continuous triglyceride suppression. Plozasiran is constructed differently. It is a double-stranded small interfering RNA. Returning to our diagram, on the right side, we see plozasiran entering the hepatocyte. But the double-stranded molecule does not enter the nucleus. It remains entirely in the cytoplasm, targeting mature ApoC-III mRNA that has already exited the nucleus. The double-stranded siRNA enters a large structure called the RNA-induced silencing complex, or RISC. The complex immediately discards the passenger strand, retaining only the highly specific guide strand. The RISC complex uses this guide strand to scan the cytoplasm, identifying and locking on to matching sequences of mature ApoC-III mRNA. Within the RISC structure, an enzyme called Argonaute-2 acts as molecular scissors, cleaving the target mRNA strand in half and preventing translation into protein. The defining characteristic of this siRNA pathway is its catalytic nature. Unlike the ASO pathway, the RISC guide strand complex survives the cleavage event completely intact. It releases the destroyed mRNA, stabilizes, and loops back to lock onto and cleave multiple mRNA strands in rapid succession. A single-loaded RISC complex persists in the cytoplasm, performing rounds of mRNA degradation for months without being consumed in the reaction. This molecular stability directly dictates how the drug is administered to patients. The catalytic persistence of the RISC complex provides deep, durable gene knockdown, which is why plozasiran utilizes an extended once every 3 months dosing schedule. These different molecular pathways were evaluated in separate phase 3 clinical trials for olezarsen and the Palisade trial for plozasiran. Trial participants entered these studies with extreme baseline severities, exhibiting median fasting triglycerides hovering between 2,000 and 2,600 milligrams per deciliter. In the BALANCE trial, patients receiving the 80 milligram monthly dose of olezarsen saw a 44 to 60% reduction in triglycerides relative to placebo. In the Palisade trial, the 25 milligram quarterly dose of plozasiran achieved an 80% median reduction in triglycerides. Both molecular platforms successfully bypassed the broken LPL pathway to achieve levels of triglyceride clearance previously impossible in this genetic cohort. Beyond the ultra-rare FCS population, these therapies scale effectively to the much broader demographic of patients with severe hypertriglyceridemia. The CORE and CORE2 trials for olezarsen tested this at scale, enrolling over 1,000 patients who were already taking standard-of-care lipid therapies but remained well above safe thresholds. Looking at the data for the 80 milligram dose of olezarsen, patient triglyceride levels fell by a placebo-adjusted 72%, decisively crossing the 500 milligram per deciliter safety threshold. This biochemical reduction translated to the hardest clinical outcome, an 85% reduction in adjudicated acute pancreatitis events compared to placebo.
Plozasiran demonstrated similar efficacy in the SHTG and MUIR long-term trials. 96% of severe hypertriglyceridemia patients successfully reached the sub-500 safety threshold. During the 2-year open-label expansion phase for patients on plozasiran, exactly 0 acute pancreatitis events occurred. Biochemical knockdown of the ApoC-III protein directly correlates to hard clinical endpoints, functionally neutralizing the risk of pancreatic inflammation for severe cohorts. Targeted GalNAc conjugation restricts these molecules to the liver, avoiding systemic exposure, and making both drugs far safer than first-generation RNA therapies. However, their distinct molecular classes still dictate divergent safety profiles. Looking at the adverse reaction section of this prescribing information, olezarsen retains a class-associated risk of thrombocytopenia. Clinical trials showed a 12% rate of decreased platelet count in patients receiving the drug. Because of this specific ASO-associated risk, patients prescribed olezarsen require routine platelet monitoring, alongside checks for dose-dependent liver transaminase elevations. Plozasiran's siRNA profile demonstrates stable hematology, with no significant thrombocytopenia signal. For these patients, clinical monitoring shifts primarily to routine glycemic parameters. The underlying technological platform, an antisense oligonucleotide versus a small interfering RNA, directly dictates the ongoing clinical monitoring burden placed on both the patient and the provider. Both drugs provide clinicians with precise tools to neutralize ApoC-III and pull patients completely out of the pancreatitis danger zone. We can organize this into a clinical decision matrix. The profile for olezarsen, marketed as Tryngolza, hinges on its monthly dosing and shorter half-life. Olezarsen is ideal for patients needing closer clinical follow-up, or situations where a shorter biological half-life is preferred, allowing the drug to rapidly wash out of the system in the event of adverse reactions. The profile for plozasiran, marketed as Redemplo, relies on its siRNA architecture. It offers quarterly dosing, catalytic stability, and a clean platelet profile. This makes plozasiran the superior choice for patients prioritizing long-term adherence and injection convenience, or for those with pre-existing hematologic concerns where platelet monitoring would be burdensome. Managing extreme hypertriglyceridemia is no longer restricted to rigid dietary interventions. Endocrinologists now possess 2 distinct, highly effective RNA platforms to restore lipid flux.